Hello, everyone, and welcome to Untangling HIE in Florida, where we aim to address the complexities within health information exchange. Today is a special day because it's our final Untangling HIE in Florida session of the year. So we are going to be wrapping up the year with a conversation surrounding the Florida HIE's Encounter Notification Service, or ENS, but more specifically on smart alerts within ENS. So joining me today is Brian Smart with Point Click Care, and in just a moment, Brian is going to give us some more information on what smart alerts are. And we also have Diana Valderrama with us. She is the Manager of Quality Improvement at United Healthcare, and Diana is using smart alerts in a real-world setting. So she's going to share with us a bit about what that's like from a health plan perspective. Now, before we get into it, I'm just going to quickly cover our housekeeping items. So all lines are muted to ensure our audience has the best audio experience possible. There will be time at the end of the conversation for a question and answer session with the audience. So you may type your questions into the questions panel on the GoToWebinar toolbar. You can do that throughout the conversation. We will be monitoring the questions, so as they come to you, feel free to type them in. We also have some materials in the handout section of the toolbar as well. We have our Untangling HIE in Florida infographic and a copy of the slide deck. So go ahead and download those and take a look at those and share them with whoever you think would find it useful. We also have our website available that has all the previously recorded sessions, so go ahead and check that out too. So with that, I'm going to hand it over to Brian so he can kind of level set us on ENS and what smart alerts are and everything. So Brian, thank you for joining today, and I'm just going to hand it right over to you.
Great. Thank you so much, Corinne. I appreciate it. You're controlling the slides, though. Yes, you are. Excellent. One thing I want to confirm, this is being recorded, correct?
Yes, it is.
Great, great. Wanted to make sure that we could send it out to anyone who could not join. So yes, good afternoon, everyone. Thank you so much for taking some time. I know it's busy with the holidays and kind of ending the year on a high note. So hopefully this will be a good break from that, give you guys some great information and great knowledge around the Florida HIE, specifically the smart alerts, and how maybe you guys as an organization could leverage them in 2024 to meet some of your quality metrics or healthcare goals or care coordination goals, whatever it might be. So yeah, we, Corinne, obviously associated with the Florida HIE. I'm the director of the Florida HIE with Point Click Care. Corinne's with ACA. And then we have Diana with United Healthcare. So all three of us combined are going to really highlight some of these smart alerts and some of the capabilities behind them. And we're really hoping to have some engaged questions afterwards, because we think that this is just a great tool that the Florida HIE with ACA's guidance has come to the forefront. And United Healthcare is one of the premier health plans in the country, in addition to Florida, and they leverage some of these smart alerts, which Diana is going to go into some details about in a really unique and robust way. So very excited about the opportunity, and thank you very much, Corinne. We can move on to the next slide. What I wanted to do here was just take a step back and talk about ENS, the Encounter Notification Service, kind of how it functions, and just give everyone kind of that 10,000-foot view. So as it stands right now, the Florida HIE receives data from acute care, post-acute care, home health, hospice, rehab, and EMS agencies. This data comes over to our system in real time. And based on when we get that data, we route it and send it downstream to subscribers. These could be entities such as health plans like United Health. It could be a provider, a big provider like Optum or ChinMed, or a really small provider. We've got some that only have 400 or 500 patients that they're trying to monitor and track to see if their patients have an acute encounter. We also have ACOs as well, and health systems, and of course skilled nursing facilities also want to receive information back on their patients. So if you think about it from this data, this kind of infographic we have here, we've got three different things. The first is number one on the far right side of your screen, data sources. These are the institutions that are providing data in real time to our ENS system. In our ENS system, It looks like a little wheel here, but really it's a highly technical infrastructure that leverages patient matching through an IBM master patient index, in addition to ADT data retention to be able to match those two up based on a list of patients that our subscribers are providing us. So there's 3 layers to that ENS wheel, and number 3 in the middle there. And if you think about the subscribers providing us data in demographics, first name, last name, address information, that goes into the middle section. And then you layer it on the data with the real-time ADT data we're receiving from hospitals and skilled nursing facilities and home health and rehab. Those meet in the middle, and that middle section. And then we perform a matching algorithm that actually sends alerts back to subscribers. These alerts can be real-time, they could be once a day, to notify them that a patient you currently have a care coordination treatment relationship with has an encounter at one of our 873 connected data sources. So if you think about data just flowing back to you consistently, that's great, and it really helps you. But imagine getting, if you're a large, United Healthcare is a great example, they may be getting 4,000 to 5,000 alerts a day across their entire lines of business. That's a lot to enlist, even if you have a dozen people working. They got to monitor 100, 250 alerts a day and figure out, are these alerts actionable for our team to do something with? That's where that last line at the bottom where it says smart alerts pumps data over. So the subscriber continues to receive alerts, but smart alerts, what it does is kind of silos off some of that data and provides it to maybe another location within your organization, or just provides it in another way that your care coordinators and the members of your team can really highlight and focus in on. I really want to focus on this particular type of alert. We call it a smart alert, to let you know, instead of sifting through 4,000, 5,000 alerts a day, maybe just look at 20 or 30, because this 20 or 30 are really instrumental to your treatment and care of patients, because it's related to social determinants of health. It might be related to behavioral health, maternal health, COPD. The list goes on and on. Asthma. We've got a lot of entities leveraging so many different kinds of smart alerts. And the manner in which the smart alerts are triggered can be customized by subscriber. So you can say as a customer, I want to know when my patient comes into the ER and says they have everything from a fever to, I overdosed, or I have heart pain, or, any sort of the patient complaint terminologies that might come up that you feel like would be critical to be alerted on. You can couple that with diagnosis codes and descriptions. So you can say, I want to know any patient that came in with a complaint of, sharp stomach pains. But then I want only that alert to come through if the diagnosis code is around some sort of maternal health condition. And then marrying those two together, we'll send that in a smart alert. And then instead of sifting through the 1,000 alerts you receive a day, you only get a few alerts that meet the specific criteria that your team has set up. And so it really kind of takes all the white noise away and allows your team to focus on exactly the type of alert you're looking to get. So to recap, data sources send data in, subscribers send patient panels in to this ENS system in the middle, and then it does a matching algorithm, and then it sends alerts back. And smart alerts is, instead of taking all 5,000 alerts you potentially receive in a day, it takes them and says, I'm still going to send you the 5,000 alerts, but I'm going to take a subset and send them to another location that your organization deems appropriate, to kind of comb through all that white noise and focus in on the specific alerts you're looking for. If we can move to the next slide, I think that's where we can get into a little bit more of some high-level scope of the breadth of the connectivity of the Florida HIE. So as we were talking about the smart alerts and the volume of alerts you would receive, this just gives you kind of a breadth of the coverage. I mean, if you look from the map standpoint, it's essentially a statewide coverage. Almost every single acute facility in the entire state is sending data. In addition to home health, hospice, and urgent care is another thing that we're pretty pleased about. we've got about 80 urgent care facilities that are contributing data as well. Because we know a lot of patients don't go to the ER, they might go to urgent care for whatever reason. It's closer, it's more convenient, maybe the wait time is maybe a little bit less. So with that, we have a large amount of organizations subscribed to receive this data. You know, the ACOs, providers, and health plans. And when you look at the amount of Floridians who are covered by this particular program and the number of volume of alerts we send a month, this allows you to really see that not only are you going to get a full breadth of data, but the smart alerts allow you to take that data and silo it off and really focus in on the particular things that your organization is targeting. You know, I can go and we can discuss more about this, but I think Diana is going to talk a little bit about some of the smart alerts that United Healthcare has set up that have really been impactful for them in prior years. It's also impactful for their claims reconciliation. It is also impactful for them to understand that maybe this patient that we didn't know about seems to be going in the ER a lot for behavioral health conditions. Let's get them in a program that prevents them from going to the ER for a behavioral health condition and gets them treatment, gets them access to resources that hopefully avoid them having another encounter like that. We see this a lot with social determinants of health. You know, United Health and a lot of other health plans are doing really great things with getting Meals on Wheels program, getting prescription drugs delivered, giving them housing, getting them the resources that hopefully will get them out of the situation where they need to go to the ER because they just haven't eaten in 4 or 5 days. That's a real problem that we experience across the nation, and especially in Florida. And the ability to silo some of these alerts out and focus in on this subset of patients seem to have multiple ER encounters associated with social determinants of health. Let's get them in a program to provide treatment and care and guide them to the path to be better health. And then let's monitor them to see, do they have any additional social determinants of health alerts? Because by siloing that data off and being able to focus in on specifically, social determinants of health, behavioral health, maternal health, COPD, asthma, goes on and on and on, you can really focus in on lowering the quality metrics and really lowering those preventable ER admissions, the PPEs and the FUM and FUH and all the measures that health plans and ACOs are being tracked on. And Smart Alerts is a great thing that can really help your organization set that up, track, monitor, and provide the services to patients it's gonna improve their care and hopefully prevent them from admitting to the ER. So with that, I'm gonna kind of pause here and I think turn it back over to Corinne, because I think Corinne, you're going to introduce Diana and talk a little bit about what she's going to talk about, which I'm really excited about because I've been working with her for years now, and United's just been doing incredible things in this space. So thank you so much.
Yeah, well, thank you, Brian, for level setting for us, and you did a fabulous job. And I'm not really going to introduce Diana. She's going to introduce herself. So, Diana, thank you for being on with us today, and just give us a little bit of background on you and your role at United Healthcare.
Thank you, Corinne. Thank you, Brian. Thank you for having me here today. So a little bit of my background, academic background, it's on public health with a concentration in epidemiology. Before coming to United Healthcare, I worked with the managing entity in Miami that handles the DCF funding for behavioral health and substance abuse services. And I was the lead evaluator for an expansion of care grant. And so I got some experience there with the behavioral health system, data analytics, and programs evaluation. After that, I came to United. I've been here for almost 7 years, and as a quality improvement manager, my main role is to oversee our our performance improvement projects. They're also known as the PIPs. If we have any health plans here, they're probably familiar with those. And as in my role, leading the PIPs and overseeing the PIPs, I collaborate with various teams across the enterprise in United Healthcare to help identify barriers and opportunities around the PIP topics. And so we have PIPs around improving birth outcomes, reducing potentially preventable events that Brian mentioned earlier. We also have a BH performance improvement project, and Smart Alerts have been really key in our strategy to do some improvement in these areas.
Awesome. Well, do you want to talk a little bit about how UHC is using Smart Alerts?
Sure. So like Brian mentioned, it's just making our process of identifying members coming out of the ER or an inpatient event more efficient. So we have implemented alerts around pregnancy, potentially preventable events, PPEs, what we call it, and behavioral health. And it just helps really make the process more streamlined, more efficient for our care coordinators and our case managers. Rather than having a big file with all of those incoming alerts, they're able to focus on cohorts, on group of members that we really need to target. And it's helping us really move the needle around goals, right? So we're working towards improving HIE metrics or PPEs. So we have set up a specific cohorts that will go directly or they're pulled down every day by our case manager coordinator. So it has improved immensely the timeliness. So they're able to see, I know we have live feeds, and basically we know every hour, every 30 minutes, every time somebody hits the ER or gets into the hospital, we're able to know, but it's impossible for our care coordinator or care manager to just be looking at those notifications every hour or every 30 minutes. So the Smart Alerts really help us streamline the process and just getting that in one file every day. We have some teams that might access it twice, in the morning and in the afternoon, but most of them really just come every morning, and it just helps that everything is in one file, and a lot of information is already there. It's not just when they go in, but the diagnosis for what they went in for. We know when they're admitted, and then when they're discharged. We even have information around their PCP who is assigned, because we shared that with Point Click Care, and they're able to do that matching as Brian explained. So it has been a really great tool just to make our process being efficient, and for reducing time for our case management team, and really them having to spend more time outreaching the member than doing administrative work in looking at the right the information they can use to outreach our members.
Thank you. Yeah, it does sound like it's really streamlining the process and getting rid of some of that extra stuff going on. But Brian, did you want to add anything?
No. I think Diana covered it really well. You know, the one thing I'll say that United Healthcare did, in my opinion, that was a bit strategic but really helped them, was that they walked before they ran. They didn't, as an organization, come to us and say, here are the 15 different smart alerts we want to set up and focus on. They really looked at a few, and in my opinion, almost perfected the manner in which, first off, what trigger alerts are we going to set? What's the timing that's best for us to receive this data? Who should have access to it? And they perfected that. And then they also made sure that once the care coordination team or the department that was in charge of the alerts, how did they do the outreach? How did they communicate back to their member? And I think once they kind of learned to perfect that and do that really efficiently, then they started adding other smart alerts and other capabilities behind it, because I think they just did such a great job initially understanding what was the benefit, what was the type of data, and let's refine that and really get that working well. And Diane, I don't know if you can talk about your team and kind of a little bit of the work you guys did with that, because I think you also leveraged a little bit to look at claims, and that's how you kind of figured out what we might need to alter. And then also you guys had, I know you've got a few people accessing this data, so I'd love to hear about your strategy around that, because I know that's something you guys came to me a year or two ago about.
Sure. So you're right, Brian. We started our implementation with our behavioral health PIP. So I want to tell you a little bit about the PIP. It focuses on improving our members' compliance with 7-day follow-up after they've been to the ER for a mental health event. And so the smart alerts were so critical, because closing that gap in 7 days, timing is of essence. If we don't know that when the member is being discharged, if it takes 2 or 3 days for us to know, it's really low chances that we're able to connect that member to care within those 7 days. So you're right, Brian. We started really slow. We asked the point-click care team to only include the primary diagnosis because we were trying to avoid any noise around any admissions that were not true mental health. So many times members could come into the ER for a primary diagnosis of any other complaint, and they might have a mental health history. And that comes into that notification, and that's not really the ones that we want to refer to our behavioral health case management team, right? So we stick only to the primary diagnosis. The only barrier that we encounter with that is, like Brian said, because we have this as part of our performance improvement project, we are constantly evaluating what's working, what's not working. Are we really identifying enough members that are falling into our HIE metric, which is called the FUM metric? And we compare it to claims. So we look at the SMART alert and say, okay, out of the members that are falling into our FUM metric, what percentage is coming through our SMART alert? And we found out that it was a small percentage. It was smaller than we expected. So we actually turned on all of the diagnosis, and we encountered that it was too much noise. So we continue to explore the data. We did more investigation. We look at some of the records in the FUM metric and compare it to the SMART alert. What we encounter is that those notifications were coming in, but they didn't have any diagnosis, no behavioral health diagnosis, zero diagnosis. That's why they were not hitting the behavioral health SMART alert, because that keyword was not there, the diagnosis. But as we continue to explore the data, this is where I wanted to go into how the HIE contains more information than just diagnosis. We look into the chief complaint, and what we encounter is that a lot of facilities were adding a keyword in the chief complaint that give us a clue that that was a mental health related ER event. The most common one was psychological evaluation. So a member going in for a psychological evaluation. So when we had these findings, we reached out to Brian and the point-click care team, and we asked them to turn those on. So we are now working with the primary diagnosis and the chief complaint. I know after we tested, we actually saw an increase in identification around almost 70% of increase. Of course, we wanted to make sure that they were true mental health related events, which our case managers were able to verify. I'm sure if they would have received a lot of noise, a lot of events that did not belong to their team, they would have, they provided the feedback, and we were actually very happy because we were able to connect with one facility that we weren't seeing VHS SMART alerts coming in. So that was a great success. We have that implemented, and we actually saw some movement in the needle for that metric last year as well. We implement other strategies, but this has been a key tool for us to be able to move the needle in the FUM metric.
And this is the type of thing that, I've been doing this for 8 years now, working exclusively with the Florida HIE. And this is the type of thing, as I'm going to call us a vendor, that moves us into a partner and moves us into someone that builds a relationship, because we can put this data back into the hands of the state, ACA, and they can help understand maybe there's more funding and more resources that needs to be driven to a particular county or region because we're seeing more behavioral health or social determinants of health needs. But then also it allows us, which is I feel like it's a strange relationship, because United Health is paying us to deliver them data, but it's such a partnership that it really allows us to understand what can we do to improve the data? What can we do to improve the relationship and open those lines of communication to make sure that we're surfacing the data for you that's going to be the most actionable? And Diana mentioned there the multiple diagnosis ability and capability behind that. And that was something we tried. And just to take a step back for folks who aren't quite aware of that, When a patient walks into an ER, they get a primary diagnosis when they're discharged. The difference is we noticed a lot of times, in some cases, the primary diagnosis might be a broken leg, but the reason is they were under substance abuse. They, were drinking or taking opioids or something like that, but they broke their leg. So the ER visit is for the broken leg, but the second, third, or maybe even fourth diagnosis was they broke a leg because they were under the influence. And that's something that can be surfaced to Diana and the team to understand that while we're obviously going to treat and pay for the broken leg, let's figure out why this patient had a substance abuse diagnosis. What's going on there? Is there history of that? Is there something that else we can dive into that might provide us to get them in a particular program to provide support? And the relationship and partner and transparency on what they're trying to achieve. And frankly, Diane can probably mention this. There were some tough conversations we had with the data. It was, this isn't good, or this is too much data, this is too little data. And they, instead of saying it's not working and walked away, they said, let's dive into this deeper and let's really figure out what we can do to solutionize something that's going to benefit us both. And what we learned was that, like Diana said, the psych eval for patient complaint was something that it seemed like a lot of acute care physicians were just entering in. And there wasn't a patient complaint provided, and there maybe even wasn't a behavioral health or any sort of diagnosis that would have triggered it. But the psych eval was what maybe allowed her team to prompt and say, let's give this patient a call. Let's maybe find out what's going on, because maybe that would drive to understand there's some other underlying issue that we can address and we can provide support for. And so United Health and Diane did such a great job in creating such a partnership and a relationship for us to push forward and continue to improve. And the great thing is we continue to improve on those. We're adding new triggers, we're adding new diagnosis codes and we're moving some. Some are a little bit more white noise and some just weren't working. So we kind of continue to trigger and play around with it to get kind of right in that sweet spot that allowed the data to be manageable, but also actionable, and didn't allow it to create additional white noise for her team, which I think sometimes is a little overwhelming, especially if the team is just starting out. They're just trying to kind of meet these goals, and we understand in the healthcare space there's pressure to meet some of these CMS goals and the state goals, and anything we can do to lend support and provide guidance, I think as a vendor, that just is a win for us, because it means we're more valuable, we're more integral in your day-to-day operations, and that's what we want to kind of help provide. And the unique thing about it, which I think some other vendors may say other things, for us, there's no additional cost to do this. We're happy to set it up. We're happy to work with your team and kind of figure out what to do. And there's no additional cost that's incurred by doing this. You're already getting the data. Help us silo it out for you a little bit to make it a little more actionable for your entire team. I always like to throw the cost thing in because I feel like people might perk up a little bit more with that.
That's everyone's favorite topic, isn't it?
Yeah. Yes.
Thank you both so much for all of that. I did want to just take a step back and talk a little bit about the initial problem, Diana, that you guys were trying to solve, and how you got to where you are today. So if you could get into that for us a little bit, that'd be great.
Of course. So the initial problem was the timeliness. So before we had the ENS and the smart alert, we had to rely on claims data. And as you know, claims may take months or 3 months for us to receive from our providers. So we definitely cannot rely on claims to close a gap within 7 days. If we had any ADTs coming through internally, they're usually very delayed. They take 3 to 4 days, and it's definitely not enough time for our care managers to engage and set up an appointment. So it was too late as well. The other thing is we don't have the solution to slice and dice the data like the smart alerts allow us, which is that focus on one cohort. So if we would download, for instance, a list of notifications, then our care coordinators will have to look on the specific behavioral health diagnosis. So that was still a burden, an administrative burden, and still taking time that didn't allow us to close the gap within 7 days. So yes, that was the original issue, and Smart Alerts have, as I mentioned before, it has really helped us streamline that process, make it more efficient, and really helping us achieve our goals, which is close the gap within 7 days.
Thank you, Brian. You've been on this journey with United Healthcare. Just wondering if you remember helping out Diana with solving this problem, if you want to talk a little bit more about that from your end on the back end of it.
Yeah, I think the thing that came out of this was sometimes organizations and United Health, they've been receiving data for 5-6 years, and getting over the hump of tell us about what you're trying to solve, tell us the problems you're having, was probably a little more difficult, I think, for both of us, because I didn't really know the questions to ask. I didn't know what their focus was. I didn't know what they were looking to achieve. And I think they didn't know the problem yet till it kind of reared its ugly head. And then once they realized this is a problem and something we need to work to achieve, how can you help? That's where I really said, yes, let's dive in. Let's work together. Let's figure out what we can do. But I was probably the one a little more like, let's crawl before we run, because I wanted to make sure we didn't do too much work that was just, it caused another mess. Because when you stand up a lot of these and you say, oh, I want this smart alert and that and this and that, next thing you know, it's all jumbled up. People don't really know how to work the data efficiently, and it really delays getting your handle around all this stuff, sometimes by a year or so. And I think United take a really great approach by saying we're going to focus in on behavioral health, and let's really identify that and get that under wraps. And then they're taking the workflow and the momentum from that and applying it to the rest. They've got COPD, they've got social determinants, maternal health. They have so many other smart alerts set up now, and they're working really well. And they're looking to set up more, because they did establish a great workflow and really communicated to us quickly. It wasn't quarterly meetings, it wasn't annual meetings, it was weekly in some instances, to really help us set everything up and make sure that they're monitoring things appropriately and not missing anything. So it was a great relationship, a great thing for us to do, and really allowed us to, it challenged us a little bit. I mean, there were some questions that Diana asked and capabilities that the team wanted that we didn't explore, we hadn't even thought about. And so it allowed our product team to kind of create some neat things and do some cool stuff, because it's one thing to send out an alert based on a diagnosis. It's another thing to say, send out an alert if this patient complaint, this diagnosis, and this description match, send it. If it doesn't have this patient complaint, don't send it. That was where the logic had to come into effect. And then we also said only send it if it's a discharge. Don't send it on admit, because they're doing that 7-day PEP that they were focused on. So we didn't want to flood them with admissions and transfers and a bunch of data. They said this isn't impactful to us. We're looking for the discharge data that meets our requirements. And that was where we had to, again, scale it back and kind of, make sure we were doing it iteratively and really in support of them the entire time. And I think in the end, it's worked out really well. And hopefully folks on the call are understanding that there can be some really big benefits to this, and really help silo some of the data off, instead of you trying to figure out how are we going to sort through all this data and throwing half of it out, maybe not paying attention to it all. We can help silo some of that off and really help you focus in on the key things you're looking to achieve in 2024 through almost anything. I mean, if it's we're just focused on discharges, we don't care about diagnosis or patient complaint or anything, that's something we can help with, and that's definitely something we're able to do with you. Custom reports that get sent. Diana's team gets custom reports sent to them every day, and it goes to different locations based on the team and how they want to work, and that's something that we can help set up and kind of facilitate. So a little long-winded, sorry though.
That's all right. It sounds like the collaboration aspect of it has really proved to be enormous in assisting United with all of the data coming in. And speaking of the data, I did want to ask Diana how United is leveraging the data. I know you've sort of touched on this already, but are there any specific examples you'd like to share with us?
So I mentioned how we leverage the chief complaint. But I wanted to, Brian, is on point about how we test or how this evaluation out of the BH Smart Alerts has really brought into light all of the other smart alerts, really to understand how we can make these actionable. We are leveraging like some of the pregnancy notifications, changing the frequency really so that our case managers are able to engage members whenever they get admitted. Sometimes we can find members who are pregnant quick enough to engage them into care and reduce the risk of preterm delivery. So this is another source of data or where we can identify those members as soon as possible and engage them into care. One specific example I wanted to mention we want to align the Smart Alerts strategy with our goals. And as we work through improving potentially preventable events, recently we identified a trend that is really driving our potentially preventable ER visits, those avoidable ER visits. And we found that a specific cohort and age group is driving that trend. And so I came to Brian and I said, can we get a smart alert that only focuses on this age group? And so that I wanted to mention that because we already learned how we can slice and dice the data with the DH Smart Alert. So now I'm coming with new ideas, really based on how we're trying to improve and move the needles in some of our quality metrics. And so, like Brian is saying, Diana has told us, okay, can we try to leverage this field? Can we try to leverage that field? So we don't have results yet. That's a new smart alert that I have asked for. But we're looking forward to, since we already have been able to implement it before and make it actionable, we have the right steps to engage our case management teams, and we're looking forward to start engaging that cohort of members and seeing results.
I would love to learn a little bit more, maybe have Diana speak to, when you guys do follow up on a patient, I'd love to know a little bit, are you looking for ways to drive and get patients in particular programs that United Health offers? I know you guys have tons of great programs, but like, is that notification trickling down to the point where now you're seeing patients or members of yours being enrolled in particular programs that are hopefully improving their care? And maybe not things that United Health particularly is providing, but enrollment in, AA meetings, enrollment in Meals on Wheels, enrollment in housing and other opportunities that you guys are seeing. And I'd love to figure out how you guys are connecting those dots, because I think that's what is really impactful with these type of smart alerts. It's one thing to get it, follow up with a patient, but it's another thing to get a patient enrolled or get a patient in a new program that's going to really help them to lower their ER admissions and hopefully improve their care in the end, which is what we're all after.
That's right, Brian. So whenever our case managers are able to reach our members, of course, in regards to behavioral health, those 7-day follow-ups are important, that they're able to connect them to a follow-up visit either with their behavioral health, with a behavioral health provider or a primary care provider. But also, usually when they engage the members, our care coordinator or our case managers will have an assessment. And based on the members' needs, they could be engaged in different programs that we offer. So if they have, for instance, housing needs, they will be referred to our housing navigator. If they have other medical conditions, they will be referred to our either disease management or our complex case management program. If they're pregnant, they could be referred to our Healthy First Step program. So yes, you are correct. That really the smart alerts are helping us not just do that follow-up, but also to identify members that might benefit from either case management or any of the programs that we offer. Like I was mentioning before, for pregnancy, we do have systems in place that allow us to identify women with high-risk pregnancies via claims. But those claims take a long time. As I said, it takes 1 or 3 months for us to have a claim. And sometimes we're engaging women who have a high-risk pregnancy way in their second trimester. So if they hit the ER within the first trimester and we get that notification through the ER, they might not have been set up with a OBGYN yet. That's an opportunity for us to engage that member and refer to our case management program.
Really awesome stuff. Just how impactful it really all is. I do want to let the audience know that we're about to get into our audience questions, but I do have one last question for Diana. But for the audience, don't forget to type your questions into the questions panel. But for Diana, even Brian too, is there anything either of you would like to touch on that we haven't touched on yet? Diana, you can go first.
So, well, just the fact that smart alerts are such a flexible tool, just take into consideration how you can look at your strategy for those helplines that are here in the call, or even for providers at their offices. I know that they also work on improving some of their HIE metrics. I know our quality team works with some of you, and the smart notifications could really help you in focusing on some of those HIE metrics and meeting some of those targets as well. So I think it's a wonderful tool. It's very flexible, and it can help you really meet specific criteria for the population and your patients that you're seeing in your office.
Yeah, and I'll second what Diane said, and I think that the key word that I heard, which hopefully everyone else heard on this call, was strategy. The smart alerts don't need to be turned on because they're a fun new toy that's shiny. It's if they don't back a strategy that your organization has and support that strategy, there's no reason to turn them on. They're not going to really benefit you. If anything, it's just one more file you have to open up and look through. So the key thing there, and hopefully everyone heard it again, is the strategy. It's these smart alerts can support a strategy that your entities or your companies already enabled. Not, we're going to start a smart alert and then start a strategy, because that's the wrong way to do it. And then you'll have it on for a year before you even realize how to work it, what to do with it, and how it's going to support the strategy. So I think that was a great point by Dan.
Well, thank you both very, very, very much. This has been really great and informative, and I think our audience is really learning the best way to use smart alerts, have that strategy before you go into it. I am looking at our questions box, and we have a few questions, but I'm reminding the audience again to type your questions into the questions panel. So the first one we have is, let me see. Does a smart alert take the place of a regular ENS alert, or would an organization receive both? Brian, I think that's for you.
Yep, no, the organization will receive both. It doesn't replace anything. It just, instead of getting, yes, it doesn't replace anything. You'll still get your normal alerts, all the same volume, but you would get a secondary alert that would basically mirror the alert you got. But instead of having to sniff through 100 alerts a day, if you get it in a smaller subset through a smart alert, maybe there's only 3 alerts that you would need to monitor. But you would still get that data. It's not going to replace anything.
Okay. Our next question is kind of an easy one. Where can we access the list of data senders?
I can Teams you. I guess I can put in the chat the link for that.
Okay. And
right. I'm good doing that.
Yeah, you have access to the chat, so great. You can go ahead and put that in there. Also, we have our Florida HIE website, florida-hie.net. You can find information on there. Our next question is there a limit to the number or types of smart alerts an organization can receive?
If sorry, one more time, there's a limit to?
Yeah, is there a limit to the number or types of smart alerts an organization can receive?
No, there is not. But again, I think back to what Diana said, strategy. You know, we want to understand your strategy associated with this, because it does take a lot of labor intensive work, and it does take a lot of commitment from your organization to get the smart alert, use it, and make sure it's working correctly. The worst thing we can do is turn on a smart alert that no one on your team's going to pay attention, monitor, work it, compare it to claims, or compare it to information that they're getting from the specific patient, because then there's no improvement, and there's no way to really get and have smart alerts support your strategy. And that's what we're after, is having smart alerts be an additional element to the main strategy your organization has.
Okay. Well, it looks like our audience is a little shy today. Maybe it's because the holidays are coming up. Who knows? But I will give everyone just another minute in case some lingering questions come in. But I do want to say thank you, both of you, for being on and talking a bit about smart alerts and ENS. And it seems to be very beneficial. And I hope this inspires some organizations to sign up and really utilize the services offered. I don't see any other questions coming in, so I guess we're just going to wrap it up. So thank you again, everyone, and Brian and Diana for being on with us today. I have included Brian's contact and Diana's contact here on this slide on the screen in case anybody wants to reach out and ask questions. This webinar, as Brian asked earlier, has been recorded, so you will receive a recording of this session probably tomorrow through email, so keep an eye out for that. And again, I just want to say thank you to everyone who has just been attending the Untangling HIE in Florida series. It has been super informative and awesome to have such great people on throughout the year. I feel like I've learned a lot. I hope everybody else has learned a lot. And with that, just happy holidays, and we'll see what comes in the new year for HIE. So thank you, guys.
Yeah, thank you, Corinne, and thank you to Aka and your support in this, because I think it's really beneficial to the entire Florida HIE.
Oh yeah, absolutely.
I agree. I come to these all the time, so I appreciate your work, Corinne. Very informative.
Thank you, thank you. It was a pleasure. It's been super fun. So we'll see what happens next year. Y'all have a good day.
Happy holidays.
Thank you.
Bye.
Bye.